So good evening, everyone. So today we'll be discussing the post-op management or post-ICU management of Impella. So this video is divided into two sections. In the next part, which is of our concern today, when a patient get Impella inserted in the cath lab and when the patient gets shifted to the ICU, what all things the nursing staff or the doctors, the residents team has to monitor while the patient is on Impella. But before that, going into that section, in the first part, we'll give you a brief about Impella. So first we'll see what is Impella, how it works. Then we'll see a very important difference between Impella and IABP, and then we'll move to next section in which we'll show you what all things we need to monitor when a patient is in the ICU on Impella. So Dr. Benjamin, can you bring the camera here? So as you can see, this is your aorta, these are iliac branches, these are femoral, and as we do in the PCI, a catheter is passed through femoral approach and it goes above this is Impella device. It goes up through the aorta and comes to the aorta, and this is the way it gets lodged. This is your aortic wall, aorta. This is your aortic wall. This is your LV. So there are two parts of this. Here is the motor, which which sucks blood from the LV cavity, and which delivers, or the output is in the aorta. So basically, it sucks the blood from here, LV cavity, and puts into the aorta. This way, the cardiac afterload is reduced. The heart doesn't need to pump the blood into the aorta. Let's see. You see, this motor has come here. This is in the aorta now. This is how Impella is planted. So we go from femoral approach, we went through the aorta, crossed the aortic wall into the LV. Now this has started sucking the blood here and delivering into the aorta. You can see here, this is how it works. You can see here it is. This is the inflow and this is the outflow. Here is what in the aorta, this RBCs blood is releasing. So it maintains the perfusion into the brain and other parts of the body. So, and when it is over, we can remove it in the same manner through the femoral approach. Now, so basically you see that it's a pump which reduces the workload of the heart afterload in specific way. It sucks the blood from the LV, puts into the aorta so that the perfusion is maintained during the procedure. Now, what is the difference between IABP and Impella? IABP stands for intra-aortic balloon pump. In IABP, the balloon inflates and deflates, and in the systole, it deflates, and in the diastole, it inflates. But for IABP to function, there needs to be some amount of cardiac output. Means LV needs to have a certain function for IABP to perform. It has to push the blood into the aorta, and from aorta, the IABP sucks the blood. Also, when the IABP inflates, it pushes the blood towards the heart back. So if your aortic wall is not competent, means if your aortic wall is regurgitated, if it is rare, we cannot put the IABP. So this is where the Impella comes handy, because for this we don't depend upon on the LV function. Even if very low ejection fraction patients can have Impella inserted into that, so it sucks from the LV and puts in the aorta. So the insertion technique is a bit easy, not very easy. The cardiologists know that. So, but the basic mechanism is we go through the femoral approach, go to the aorta, cross the aortic wall, lands into the LV, from where it sucks the blood and delivers into the aorta. Now we have a patient in the ICU in which we have just inserted the Impella, and once the patient with Impella is in our ICU, what all things the nursing team and the ICU team needs to monitor, will give you a brief idea, so that in future, in many of your centers, if Impella comes to your ICU, you will be a little bit more comfortable. So we'll move to next section. Thank you. Okay, so now we are in the ICU and Impella has been successfully implanted in the patient. The procedure has went successfully. Now the patient is in ICU. So now I have with me Dr. Kamlesh, who is from Impella team. He will tell you what all things are required for ICU residents and nurses to see when a patient gets shifted from cath lab when an Impella is implanted. So what are the identification things, what are the parts which you need to identify, what are the parameters you need to know, what things need to monitor, and we'll have few things about troubleshooting. So now we'll go at the patient bedside and Dr. Kamlesh will tell you these all things in a sequential manner. Thank you.
So today I'm going to talk you through what you see on this screen of AIC. AIC is an acronym that stands for Automated Impella Controller. So this console monitor, first we'll go from top to bottom. First on the top you will see a red color waveform. This we call it as a placement signal. So placement signal is nothing but your aortic pressure waveform, and this is produced with a pressure transducer which is located just proximal to the motor housing unit of Impella catheter. So this also helps you to understand the right position of the device. In normal circumstances this should always be a aortic waveform. If you see this a very tall ventricular waveform, it indicates that your Impella device is too deep seated into LV. So in that situation you have to pull the device back. Now you can see there are numbers. For example, in this patient you can see there is a systolic blood pressure, then there is a diastolic blood pressure, and there is a mean arterial pressure. This reading help you to determine the pressures. However, there are a couple of things I wanted to highlight here. Impella is a continuous monoaxial flow device. When patient is on Impella, usually we always monitor mean arterial pressure instead of systolic or diastolic pressure. Second thing is that Impella is a continuous flow device. It's not a pulsatile flow device. That always needs to be taken into consideration. So if your patient's native heart is very weak or very poor, then you can sometimes end up seeing this waveform as a flat line. It indicates that your native heart activity is very, very poor. Now, one more thing I wanted to emphasize, we always recommend to have separate arterial line to rely on any clinical decisions, because this is line you cannot make it zero. Now coming to there is another waveform you can see in the green, which we call as a motor current. So Impella has a motor and that rotates at certain RPM, creating a suction. So for this motor to displace the blood from one unit of the heart, one chamber of the heart to another chamber of the heart, the motor has to create certain amount of electricity, which is measured in milliamperes, and this electricity varies with every beat of the heart. So the motor current in short is nothing but the amount of electricity generated by the motor. Now as a clinician, how should this matter to you? So in ideal scenario, this motor current should always be pulsatile. When you see the motor current is flat, it means both the inlet of the device and the outlet of the Impella device, they are in the same chamber. It can be in LV or it can be in aorta. So which is completely wrong, I need to adjust the position. So to summarize, the placement signal along with the motor current will help you to determine the right position of the Impella device. Now let's come further down. You can see there is a maximum and minimum flow, and there is a mean flow. So it's a maximum, minimum and the mean flow of the Impella, and in this particular patient you can see the maximum flow of 2.9, minimum flow of 2.2, and the mean flow is 2.5. Now remember, Impella is a continuous flow device, but it's not a constant flow device. So Impella is preload dependent and afterload sensitive. So anything that will change the preload and the afterload condition will impact your ultimate flow. So to get the optimal flow, you need to adjust both the preload as well as afterload condition. Now there is a purge pressure and the purge flow that you can see, and both these things can be determined automatically by the system. So you don't have to manually adjust this. So the purge flow range anything between 2.5 to 30 ml per hour, and we always use dextrose in the purge. We never use sodium chloride. Dextrose can be used either 5%, 10% or up to 20%.
Dr. Kamlesh, can you just show us this device unit also? What are these signify? These are in the patient inside, no?
Yes, so it's just part of the catheter. Now you can see there is a red Impella plug which has various chips and microsensors. It basically stores all the patient hemodynamic data.
Okay.
Then you can also see there is a clear side arm which is connected to your pulse system. There is a air filter and there is a reservoir which stores the 5% dextrose.
Okay.
And you can see there is a red side arm here on the corner. So this is connected to your sodium chloride with a pressure vac, as you can see in this particular patient. It helps you to create the placement signal as I explained earlier.
So my question is, if we replace, if by any chance we put dextrose in it, will it hamper the functioning of the motor?
You mean the normal saline replaced by dextrose, or
No,
dextrose replaced by normal saline?
Per system, if we replace it by saline,
Yes.
what can it do?
Yes, so that's a very great question. So when it comes to the purge, we always recommend to use dextrose because dextrose has the right viscosity that helps to maintain the health of the motor, which is a very sensitive part of the Impella device. Normal saline has a sodium ion which can crystallize the motor, and when the motor crystallizes, then your life of the motor also goes down. So we never recommend normal saline to be used in the purge system. Sometimes people ask us a question, what is the patient's diabetic? So if you look at the flow, the maximum flow is 30 ml per hour, which is not significantly high. And anyway, most of these patients who are in ICU, they are quite critical and they are on insulin protocol anyway. So that should not impact much on the patient management.
And this saline system is for the arterial line placement or for some other thing?
No, this saline actually enters just proximal to the motor. There is a small opening called open pressure port from where this saline exits.
Okay,
So
but for
just
the motor?
in the ascending aorta.
Okay, but for the motor per se, we need to use dextrose.
Dextrose, correct.
So what I can understand from this is these two graphs helps you determine the what is the position of the impella,
Correct.
whether they are in the aorta, whether they are into the ventricle. If they
Yes.
are both in the ventricle,
Yes.
then your motor current system will become flat.
Yes.
If it is a flat, then means it is not in the two separate chambers. But
Yes.
the pulsatile one, the BP
Yes.
which is recorded by the placement signal, if it is flat, then it can be due to low function,
Cardiac activity.
low cardiac output state.
Yes.
And we rely more on the mean arterial pressure rather than the systolic and
Yes.
diastolic
When it
pressure.
comes to Impella, correct.
So thank you, Dr. Kamlesh, for this. Any troubleshooting or anything which can happen or which the staff needs to be vigilant for
Yes.
this?
Yes.
For when the patient is on Impella?
Yes, so there are a lot of alarms and troubleshoots which are there. We have dedicated training module for that, but for sake of simplicity, I will just summarize it.
The
So
common ones.
when it comes to Impella, I think the most important thing you have to monitor any signs of alarm which is shown on the top of the screen. Right now it's empty, so there is no alarm, but if it's any alarm, it will show on the top of the screen here. Now there are three types of alarm. One is a white color, one is a yellow color, and one is a red color. So white color alarm is more of a notification. It's more like information for you to take into account. It's not any actionable item, so it just provides you certain information. Yellow alarms is something where you need to act. It may not be immediately, it's not very urgent, but you need to act on it. And red color alarm is the most critical or most dangerous, so you cannot wait to act on that. You need to act immediately when you see a red color alarm. For example, if the position of the device is changed, like both inlet and outlet are in LV or they are in aorta, that will be shown as a red color alarm on the screen, which is very critical, and you need to act on that as quickly as possible.
Okay. Now the staff is there, staff which is taking care of this patient. Do they need to do anything continuously so that
Yes.
the system works
Yes.
without
Yes.
any disturbance?
So there are two. I will divide it into two parts. One is more of a operational part, and one is more on the patient management part. So when it come to the operational part, I think as you can see there are two things which are attached to Impella. One is a normal saline and one is a 5% dextrose. So whenever you see this are being emptied or about to finish, you need to replace it, and there is certain process that we take you through that how to do that. It's very easy process. System is so well trained that it tells you step by step how to replace those things. So that is something you have to do routinely whenever patient is on Impella in the ICU. Now second is the patient management part. So this is more of a strategic part. And when it comes to Impella patient monitoring, there are certain things you need to unlearn, which we have been doing over the years. And I will take you one by one. What are the parameters you need to monitor when the patient is on Impella? The first thing is mean arterial pressure. So on Impella, our recommendation is to have mean arterial pressure 60 or above. If the mean arterial pressure drops below 60, then you may need to escalate it to the next level of therapy.
Okay.
Now, second thing that we always tell when it comes to patient management on Impella, your inotropes and vasopressors should be reduced as quickly as possible and should be stopped ideally, because these are the drugs which are extremely toxic. They increase your myocardial oxygen consumption substantially, which is against the principle of native heart recovery that we want to see when the patient is on Impella. So that is the first thing we always recommend, to wean off inotropes and vasopressors as early as possible when patient is on Impella. Now second thing that you need to monitor is the lactates, because lactates is a surrogate marker of your end organ perfusion. Lactates should always be in downtrending, and there is a data published by NCSI. If after 24 hours of support, if your lactates remains above 4, then your survival chances reduces. If your lactates are less than 4 and your patient is on no inotropes or vasopressor, then your survival chances are very high. So I think these two are very important indicators when it comes to Impella. There is another parameter which is mentioned and which ideally needs to be monitored when patient is on Impella, is the CPO, that is cardiac power output, which is nothing but your multiplication of your cardiac output and your mean arterial pressure divided by constant, which is 451. CPO is shown to be a strongest predictor of in-hospital mortality when the patient is on Impella. So CPO ideally needs to be monitored. In order to calculate CPO, you need to have cardiac output, and for cardiac output there are different ways you can do it, either by right heart cath, by continuous cardiac output, or with the PI pressures or FIC methods. So there are n number of methods you can measure cardiac output, but we recommend, based on the clinical trial data, to have right heart cath when patient is on Impella, particularly for cardiogenic shock indication.
Okay, and now one more question. Do the patient on Impella requires heparinization per se for Impella, or it is not that important?
Yes, heparin is required. We recommend to use 25 units per ml of unfractionated heparin in dextrose.
No, in systemic coagulation, systemic anticoagulation is required for
systemic. Basically, the heparin helps to health of the motor. That is a more important function than systemic coagulation. And recently, although this is still, I would say, work in progress, but we are also working on using soda bicarb instead of your heparin.
Okay.
So that is also in particular in patient who has some sensitivity to heparin.
But per se, I think for this device, we don't require too much of heparinization.
Yes, we don't require.
That is one benefit.
And the ACT requirement is also slightly lower than what you see in VA ECMO. Like we need to have ACT between 160 to 180 with these particular devices, which is not that high compared to some of the other devices.
That is good. For how much long this Impella can be there with the patient?
So as per the US FDA approved indication, Impella CP you can keep up to 6 days of support for patients with cardiogenic shock. You can also keep it for further extended, but that become off-label use of the device. And I just actually wanted to add couple of more points which we need to monitor when the patient is on Impella.
Okay.
So lactate I already mentioned. Then urine output needs to be 30 ml per hour. If it drops below 30, you need to think about the various strategies including CRRT.
Okay.
Third thing is your mixed venous oxygen saturation. It has to be 60 or above. That is has to be there. Your wedge pressure needs to be between the 10 to 12 range. Your CVP has to be 10. Our target CVP is 10 because we don't want this patient to be hypovolemic, and that can create suction alarm, and it can also cause hemolysis. So CVP ideally needs to be 10.
Okay.
So these are the things which we need to work. In terms of monitoring, there are a few more things. You need to, apart from urine output, you also need to monitor the urine color. If you see the pink or red color urine, it might be because of hemolysis. So you need to
Very
diagnose that.
important.
Second is you need to also monitor the distal limb perfusion, the color of the skin, the temperature of the skin distal to the impella, because that can also potentially impella can cause distal limb ischemia. Although it's not common, but we need to be vigilant for that.
Yeah, we need to monitor. Thank you, Dr. Kamlesh. But I would request before ending this session, this ending evaluation, if we can just look at the connections which are coming from the patient, from the device and the flush. That will be hopeful. That will have help to our residents and staff which is syncing. So I'll just go through this. So this is the device. I think 2 connections are coming. If you can finger point those.
Yes.
One is your dextrose flush which is
So
coming.
this is a clear side arm which is going to your 5% dextrose, and this red color thing is your sodium chloride or red side arm that we call.
This
which
is
is
going
connected
towards
to
the
your
patient.
sodium chloride.
From
So
the
both of them are actually going inside your ascending aorta.
so-
One is just proximal to the motor, and this is actually going at the outlet, which helps to push the blood away from the motor to avoid blood entering directly into the motor.
That is dextrose one.
That is dextrose one. That's
one.
we call it
So,
purge.
so both the flush are going inside the patient.
Yes,
The flow
correct.
is towards the patient
Correct.
from the flush. You can see the flush are there. One is dextrose and saline, and they are going to the device and they are going inside the patient. The coming out one is, I think this is the impella circuit, and
Yes.
this is going towards.
This is your impella catheter, which is going inside the patient,
And
and this is your white connector cable. So your impella device basically draws its power from this AIC through this white connector cable.
Okay. Now, Dr. Kamlesh, one question which one of the staff has asked, that now you have managed this patient very well. Now patient is doing fine. What are the parameters, and when you will decide that this will remove this impella from this patient? Can you brief in short about this?
Yes, that's a great question. And weaning as such, particularly in patient with cardiogenic shock, is a little bit complex thing, and you have to rely on many parameters, not rely on 1 or 2 parameters to make the decision whether to wean or not. The first and foremost important thing, when you decide to explant the impella or start weaning the process, patient should never be on any inotropes or vasopressors. If the patient is on inotropes or vasopressors, it means that patient is not yet ready for the weaning. So that's the first and foremost important thing. Now let's assume that patient is not on any inotropes and vasopressors. Now there are 2 things you can do. You can do the rapid weaning test. So the maximum impella flow, which is a P8, you can reduce it to P2 level, and you can see how the patient behaves in terms of mean arterial pressure. You can simultaneously do the 2D echo testing, the native heart contractility also you can check. And then if you have right heart cath, then you can also check the PA pressure and cardiac output. So ideally when you start weaning, when you turn the impella flow down, then your native heart should kick in, because total cardiac output is equal to the cardiac output provided by your native heart plus the impella flow. So when you reduce the impella flow, and if your native heart is fairly recovered, then it should kick in and it should compensate for the lack of impella flow. So that's how you should see a response. And when you see that type of response, then you start a slow weaning. So from P8 you reduce impella flow to P6, wait for a few hours, how the patient is doing, how the lactates are doing, how the urine output is doing, whether there is any drop in a mean arterial pressure or not, whether there is any drop in the cardiac output. So all those things you have to monitor, and if you don't see any drop or any adverse changes, then you again reduce the flow from P6 to P4. and again wait for few hours, how the patient is doing, the lactates, all those things which I mentioned, and ultimately you have to reduce the flow to P2. If at P2, which is the minimum level of support, if the patient is fairly doing well clinically as well as the parameters which I explained, then I think this patient is ready for the explantation. Then you start the process of explantation.
Okay, so the range is from P8 to P2, or there is
Yes.
something above P8 also?
There is a P9 also there, which we call boost mode in Impella 2.5 and CP.
Okay.
But that boost mode is just for temporary, for 5 minutes of additional support.
Okay.
So for practical purpose, the maximum flow is P8.
So on P8, we have now this patient was on the P8 mode,
Yes, this patient which you are talking about is on P8.
and so the flow which was generating is somewhere around 2.5
2.5 liters, because
Five.
that's what the Impella 2.5 should give.
And at P2, what amount of flow it generates?
It depends on because there is a range, there is no exact number.
Okay.
At any given level of the flow, there is your motor rotates at fixed RPM, but the amount of flow is always in the range, because Impella is a preload dependent and afterload sensitive. So even at P2, you may get different flows. But one thing for sure, as your RPM reduces, your flow is definitely going to go down. So it may be below 1 liter of flow that you should expect.
Okay, means this is the pressure which the Impella is generating. So P8
Yes.
is a higher pressure, means the
It's not pressure, it's a cardiac output.
cardiac
basically.
output. Cardiac
Yes,
output.
yes.
Okay.
So Impella increase both actually your pressure as well as cardiac output, thus ultimately impacting your cardiac power output in a positive way.
Okay. Okay. Many thanks, Dr. Kamlesh. I hope this video will be helpful and will give boost to the residents and nurses who are taking care of the patients on Impella. Thanks a lot.
Thank you for the opportunity.
Thank you.